before we start, just want to thank all of you for taking the time to join this roundtable. I'm glad that we can have this level of conversation with folks who have done this work, are doing this work. So we're not just talking, this is actually informed by action, and we see how we move forward. So thank you so much.
Thank you, Marianne.
It's a pleasure. And a subject so needed because COVID has put the problem in the shadow, and there are many, probably many women who are dying just because interruption of services. And it's important to think about that for the next time, because this is not going to be the only one.
Yeah.
Good point, very good point.
And Raquel, just let me know when you want to start, and I'll pull down that graphic. And
yeah, then we can start. Thanks, Colum.
Yeah, good to go.
No.
Yes. Good morning, good afternoon, and good evening to our audience from around the globe. I hope you are all well and safe. Welcome to this Devex World 2020 session, co-hosted with MSD for Mothers. We will be discussing today how to overcome barriers to implementing innovative solutions for maternal health at scale. My name is Raquel Alcega. I'm an associate director at Devex, and I will be your moderator today. I'm glad to be joined by global experts and government officials, and cannot wait to hear their insights into this very important discussion. Let me do a first round of introductions. We have with us Dr. Samuel Oyenigi, the head of the Safe Motherhood branch and the Planning and Monitoring and Evaluation unit at the Ministry of Health in Nigeria. We have Dr. Isaac Bashir, head of the Family Health Department at the Ministry of Health in Kenya. Professor Agnes Binabajo, Vice Chancellor of the University of Global Health Equity and former Minister of Health in Rwanda. Dr. Marianne Etievet, Lead and Executive Director at MSD for Mothers. Temitayo Erbobo, Global Advocacy Director at MSD for Mothers too. After our discussion with all these great panelists, we'll be taking answers from our audience. So please feel free to add any questions you might have in the Q&A chat box that you can see in the bottom of the Zoom screen. We will also be recording this session, and we will be publishing the takeaways in an article in the coming weeks. This roundtable on the scalability on the barriers to the scalability of private sector solutions in the health ecosystems is very timely, because precisely today the WHO is also hosting a discussion on how the private sector can strengthen health systems to help achieve UHC. You will see how we keep referring to the WHO work during this session, because at the end of the day, we are all here working toward the same goals. Devex and MSD for Mothers initiated a partnership 2 years ago, and our goal is to measure how much donor agencies are investing in private sector solutions to improve reproductive, maternal, newborn, child and adolescent health, or also known by us RMNCAH. After lots of the conclusion that data was not available, and there was no way, no methodology that would get us closer to any robust figure or data on how much those investments were. However, we're still continuing with our efforts and research and advocacy by hosting events like this one, and by also conducting deep dives on what, and how each major donor agency is engaging with the private sector in the RMNCAH agenda. Our shared goal at the end of the day is to shed light on opportunities for the global health community to collaborate with the private sector, not only from a funding perspective, but also from, taking into account the innovation, the expertise, and the business-minded best practices. We just launched earlier this week on Monday our latest research in a report, in a 9 pages report, which includes a deep dive on how the Global Fund is currently engaging with the private sector from a both funding and a solutions-oriented perspective. We will be publishing 8 more of these, donor profiles, deep dives in the upcoming months. And I would love to invite you all to contribute to our research and, and our efforts with data, with funding data, with case studies, or with any other type of insight you might want to share. Together with our research, we have also been holding this year a lot of discussions with global health experts to discuss, among others, the role of the local private sector providers in providing care and delivering solutions to the community during these COVID times and beyond that. But let me pause here, and I believe like Tayo can help us contextualize much better how we got here and what has led us to this conversation on barriers to the implementation and scalability of private sector health solutions.
Thanks very much, Raquel. I'm not sure whether I can necessarily do it better, but let me add some additional perspectives. And I also want to thank our distinguished speakers, including the representatives from the Ministries of Health from Kenya and Nigeria. On behalf of MSD from others, thank you for honoring our invitation. So as Raquel mentioned, I'm the Global Advocacy Director for the MSD from Others initiative, which is MSD's $500 million effort to help reduce or end maternal mortality across the world. MSD is also known as Merck in the US and Canada. As Raquel also mentioned, I think it's apt that we're having this conversation today, given the parallel conversation that's going on at WHO today, where they're launching the new strategy for navigating private sector engagement for UHC. And to quote David Clark, who leads the health system and governance financing at WHO, we've been talking about private sector engagement for a long time. We need to move to action at scale. We started this journey on maternity matters, funding the future with Devex, understanding 3 high-level facts related to our MSCH. The critical, first of all, the critical role private sector plays in its capacity in low middle income settings. For example, we know that 40 to 70% of reproductive health services are delivered by local private providers in these settings. The significant role that donors play in investments and influencing health policies and practices in low to middle income settings as well. And last but not least, we also understood the gap, the glaring gap in provision for our MCH services, which the World Bank puts at an estimated $33 billion annually, which, as we all know, is only going to be exacerbated by the current pandemic. It is this quest to understand how to bridge that gap that has brought us together, and we are really honored to be able to have your perspective on this as well. But before I go on, let's take a moment to understand a bit more about some of these gaps and what it actually means for our MCH services and for MSD in terms of our mission in reducing maternal health goal across the globe. In 2017, WHO AFRA estimated out of the global healthcare workforce shortages of 14.5 million to deliver UHC and the SDG goals, the African region has the most severe healthcare worker shortage, which is estimated to reach 1.6 million by 2030. UNFPA estimated that there are some 230 million women in developing countries who want to prevent their pregnancies but are not using modern contraceptives. The cost from 2020 to 2030 of unmet needs for modern family planning is estimated at over 60 billion across 120 priority countries. And yet we know that if we bridge that gap in terms of unmet needs for FP services, we can reduce over a third of global burden of maternal deaths. And last but not least, if you look at recent research just last year, published by the Lancet Hematology, from a consortium of American hematologists, they revealed that across 180 countries they analyzed, 107 of them had insufficient blood supply to meet their needs. Yet we know that postpartum hemorrhage is the leading cause of clinical cause of maternal deaths across the globe, and not least in the Africa region. It is clear, given some of the enormous challenges, even pre-COVID, that government can't do this alone. And actually, when we look at the SDGs, government wasn't called upon to do this alone. SDG 17 specifically calls out private sector collaboration to bridge the gap that was apparent 5 years ago and is really very apparent now today. And also the burden, as we know, is getting wider. As Raquel mentioned earlier on, the good news actually is donors are engaging with private sector and utilizing private sector capacity and resources to meet the health system demands. But what we found out 2 years ago was that they weren't tracking these engagements, and they weren't formally able to communicate some of these investments in a coherent manner. Since then, through this partnership and others, donors or donor organizations have actually been very deliberate and systematic in the effort to track their engagement with the private sector. But what we're seeing now, we're understanding through this tracking process, is that challenges and particularly the barriers to scale of some of the great work that has been done to help us meet this gap that we see in terms of RMNTA services and funding. There are 3 areas we've identified for our panelists to explore, and also the audience. The first is the barrier to integrating local private providers. We heard from our good friends at AMREF Africa the challenge governments have in contracting services, that the policies and processes very often just aren't there. Secondly, limitations and barriers. We were hearing about strengthening local private health business infrastructures that serve health systems. We heard from the GFF and WHO regarding this, that the lack of integration of local private health businesses, who, as I mentioned earlier on, are already within the system, because they're not formally integrated into the structures, the business model that they currently run is not sustainable, because they're not being, the services are not being procured in a systematic way, for example. And last but not least, data and digital technology integration. Many organizations mention the lack of data, and this is important because the lack of data in terms of what is happening regarding in the private sector, for 2 reasons. One, from an implementation perspective for care, but also investment. How donors and others can invest in private sector is very poorly understood, because they don't really understand the scope and the magnitude of some of the work that is happening with the private sector, and also government policies as it relates to them. So hearing from those around the table today will really help us to be able to work with donors and others. And as Raquel mentioned earlier on, the work that WHO is undertaking in terms of guiding countries on private sector engagement will be informed by this conversation. And as we go forward, some of the insights we get from you would help us in terms of areas to explore further. So I'll pass back to Raquel, and thank you again for joining this conversation.
Thank you, Tayo. Very, very, really good. Good insights. I love them. Precisely due to the WHO launch of the new strategy on how to engage with the private sector in health service delivery. Dr. David Clark, who is the UHC and Health Systems Law team lead at WHO, couldn't make it to this roundtable today. However, we were able to coordinate with him earlier, and he has made a short video answering one key question I think very useful for all of us, not only here in the roundtable, but to all our audience, which is how can the global health community, meaning all of us, donors, experts, governments, local health providers, how can we support this new WHO strategy to engage with the private sector? And we will take out the video for his answer.
The reason we produce the strategy is that our vision is that a well-governed health system is a health system where both public and private actors can collectively contribute towards efforts towards universal health coverage. And to do this, we aim to build the consensus around the ways and means of engaging the private sector as part of these efforts, building understanding, fostering relations, enabling stakeholders, aligning structures. Collectively, these governance behaviours represent a shift and represent a new way of doing governance business. The first strategic area is to use WHO's convening power to build political will to better manage mixed health systems. Here, our ask of you is that you become part of this movement to work with governments and WHO to stress the importance of better engaging the private sector as part of efforts towards universal health coverage. Our ask of you is to contribute to implementation plans at country level for private sector engagement and to help to develop indicators. The fourth strategic area is to support learning and technical guidance in this very important area, and to contribute to the knowledge base about how we can better and effectively work with the private sector to leverage health for all.
Well, I really think the answer leads us pretty perfectly to our discussions with our expert panelists. As mentioned earlier, we will be taking questions from our audience at the end. So, feel free to ask them in the Q&A chat box that you can find in the bottom row on Zoom. As we have been hearing from Tayo, there are several ways where donors, have been engaging with the private sector and leveraging private sector capacity, expertise, approaches, etc. They are not necessarily new approaches, but we have seen that scaling them is quite a challenge. Here, what we would like to do is exploring a bit more the barriers that have stopped some of those opportunities to really reach their optimal impact. The COVID pandemic, as kind of like we were just chatting before this roundtable, has really surfaced a lack of capacity within our health systems around the world, not least in low and middle income countries, but more broadly. And our MNC services have been largely disrupted due to that. One potential solution is leveraging the capacity of local private sector providers within the health ecosystem, noting that these local private sector providers in low and middle income countries, and certainly in the countries that are represented in our panel today, provide between 40 to 60% of reproductive health services. So taking that into account, I wanted to ask Dr. Isaac, what do you see as the major blocks in integrating these local private sector providers into the wider health system response?
Thank you very much, Raquel. You forgive me if I misspell your name or mispronounce your name. It's an honor to be here today discussing this important agenda. The question you've asked is why is it difficult? What are the blocks? What are the barriers to this issue of integrating into the private sector? I'm not sure whether I would discuss the barriers or the steps that Kenya has taken in terms of really integrating the private sector. If you are mentioning issues of innovations and scalability, yes, there's a few barriers which I can allude to. But if you are talking about integration of private and public sector, I can also address that. As far as the new innovations are concerned, one of the issues that usually make it difficult for government to take up or own up is the lack of involvement in the initial phase consultation process of the concept notes for the government. That's one. And number two is the design of the intervention in terms of in relation to the context of the country, the legal environment, the practicability of the scale up itself, the capacity of the country in terms of human resource challenges, and maybe if it is techno-based, whether the network coverage for that particular country is actually appropriate or not. Another thing is the cost of scalability is an issue. You may be looking at 1 or 2 facilities and then find it really very important to very nice results. When it goes on a scale, first thing is to scale up something from 10 facilities to 10,000 facilities is a totally different ballgame. And usually getting government to fund such new innovations is quite a huge task because the budget is already overstretched in terms of the priorities and in terms of the resources available. And then the issue of advocacy in terms of the results of the innovations that we have carried out and found out to be useful, it requires it to be worked in terms of advocating to the government entities to understand from your perspective. So advocacy itself in this area is a bit maybe not as expected. And you need, for advocacy, you need to go back and go back and go back. You don't have to hit one time and then when you get a barrier, you chicken out. Then there are a lot of government bureaucracies, I must admit. And an innovation in one particular ministry or in one particular sector may not be an important factor to the controllers of the budget. The National Treasury, for example, requires for you to decipher this information into a language they understand. And that translating that policy into resource mobilization itself takes time. And Treasury being overwhelmed by a lot of requirements, a lot of requests from different sectors, it becomes very difficult. Just a few weeks ago, we were doing our midterm expenditure framework, and you will see the kind of cutthroat competition for very important agendas. And they will just pick 1 or 2 that they think is priority for them and drop maybe 20, 30. So these are some of the challenges that we have with issues of innovations. But as far as private sector integration is concerned, we may not be at the expected target level, but in Kenya, I think we are trying a bit. One, the health system. With that, we were actually, the clients were able to use both private and public facilities, and the government was able to refund, to reimburse the expenditure that the private sectors were incurring in treating these clients who have the cards. And the NHIF, National Health Insurance Fund, what do you call, accredits both private and public facilities at the same level. And the private facility, the card holders or the insurance holders will go to any facility of their choice. It will be treated and they will be reimbursed. The facility will be reimbursed. So these are some of the issues that Kenya is trying to undertake. There's also what's called the total market approach, which we have developed a policy for and guidelines. And this specifically touches on family planning services and commodities. We also have what's called the private-public partnership, or now it's called private-public collaboration. The policies and structures are in place. We have been struggling with this for a while now, but I think it is taking off. So also, some of the essential commodities that the government provides, we supply both public and private, whether they are a high-end hospital or a small clinic in a village. We supply, for example, essential commodities like vaccines for free. We supply ARVs, TB drugs, and family planning for that matter. And these are very essential commodities. And we get data from them, and our clients are treated wherever they find convenient for them. So with those few remarks, the issue of the capacity, for example, to implement some of these policies becomes a bit difficult in terms of funding the scalability, in terms of taking these laws forward, coordination mechanism, trainings that come with these new innovations or this integration work. Government has already put its funds in human resource, it has put its funds in commodities, equipment, policy direction, healthcare infrastructure, and therefore it becomes very difficult for them to find resources for this software, which is supposed to work the hardware and make it the hardware more functional. And I think it's time then, therefore, the private, especially the NGOs or the donor world, comes in to help on this softer part of trainings and capacity building in terms of the new innovations that we have. And therefore, the government can provide policy direction and structure, provide leadership and advocacy and political goodwill, which you are alluding to as issues of environments, policy environments that can have sustainable interventions of partnership, and providing consultative forum, both at different levels of government, because county government is a different government and national government is a different government, with the private sector and with also the NGO world to exchange views and strengthen. So I would leave it at that unless you have questions.
No,
and I hope I have responded to your question.
Yeah, thank you very much, Dr. Isaac. Really good remarks. And I know that you said a lot, and would love to have more time to dig deeper in some of your answers. But before we do that, I wanted to also ask Dr. Samuel, and get the perspective from Nigeria on precisely also these major blockers and barriers integrating local private healthcare into the wider health ecosystem, and also what the government in that case is doing to overcome those barriers. Dr. Samuel, are you there?
Yes, thank you very much. Thank you very much. Nigeria, we've done a lot in overcoming the barrier, especially the involvement of private health sector in delivering health services. Before now, there are policy documents that has restricted the implementation or the engagement of private health sector in Nigeria. But those policy documents for enabling environments are being worked on. Some have been worked on. There are a lot of them. Like for example, the engagement or the use of PPMVs within the community. These are people that are closest to mother and children within the community. Most of the time, they are the first point of call. So there is a lot of policy change. There is a bill in the National Assembly that is being looked into to categorize PPMV in terms of implementation, what they will do to create enabling environment for their engagement within the community. We also have the home delivery, the traditional birth attendants. These are sectors within the community that also support delivery. Presently, we have a situation where we just use them as social mobilizers to move maternal issues, newborn issues to the facility, nearest facility. But the policy is gradually changing. There's a need. Some states are now engaging them more within the community to get them involved. So policy change is a major problem in Nigeria to enable them to do what they're supposed to do to support health sector in Nigeria. I want to say it's like other places, 60 to 70% of our population patronize private health sector in Nigeria. Apart from the policy issue, maybe a legal issue in using the private sector within the country, another barrier is the population. Nigeria is very big in terms of population, the demographic issues in Nigeria. So the population that we have is like a barrier to be able to scale up to where we want to be for us to have the impact of the use of private health sector within the country. There are other issues in terms of private health sector use that we need to also look at as a barrier. There are some human factors that are serving as a barrier for it. For example, we have low health-seeking behavior under human factors as a barrier for private health sector use. Some don't even take the decision to seek help early enough, even within the community, the nearest health facility or nearest health sector within the community. So it's a serious issue. Another barrier is beliefs within the community. The belief, even if you engage the private sector, health sector, the belief of the community, of the people, their belief can be a barrier in using the private health sector within the system. The health system factor within the country is also there. Some still believe in traditional system of seeking health. They still believe in it. So it's very important. The traditional way of treatment is very high within the country, especially some areas within the country. The socio-economic factor is also a factor as a barrier within the system. Poverty is a thing. The private health sector within the system or within the communities or where they are, you need the out-pocket expenditure is very high. There are some that are profit-oriented. So it's a thing. So they resort to alternative. So these are barriers that we look at.
Thank you very much.
Okay.
Yeah, thank you very much, Dr. Samuel, for all of these barriers. It's good to see that there are some that are the same across countries, and also to also see that each country has its own idiosyncrasies and issues. Thank you very much for sharing all this great overview. I'm sure we can get more into it as the conversation goes along. I wanted to ask Professor Agnes that as she probably knows, creating an enabling environment for a viable business model for these local providers has been raised as a major challenge. Do you think that governments are able to contract these services from these local providers, acknowledging that there's a gap that exists in the provision of quality health care?
Not only I believe, yes, but I believe it's an obligation, because what we have in our continent, the public sector will never be big enough everywhere to give the service to the people. And on the other hand, the continent, the rate of poverty, as the two previous speakers have said, the level of poverty is an handicap to go and seek services when a private sector entity is near their home. So it is working together that is a solution for each and every African to get access to care when they need it. And there are successful model of public-private partnership. And in my country, what I can say, we have what we have that, meaning we have even more, what I'm calling myself public-private community partnership. You have in a remote area, the community build the infrastructure over the last Saturday of the month when there is community work, etc. Do you have the Ministry of Health who make sure that the person is educated, the person is paid, the person is monitored and evaluated, the person get access to the medicine the community need, and the supply chain is working. Third, we have that person who is there who acts as a private person. She bill every services, and the health insurance, we have the community health insurance. 90% of the Rwandan have that as insurance. And the other Rwandan have private insurance or have the public servant health insurance. They are reimbursed. So you have a private person working in a premise built by the community, giving quality services monitored by the Ministry of Health, and people reimbursed by the health insurance valid in the country. You have also another public-private partnership. You have 5% of the profit of private insurance that are given to the community-based health insurance as a solidarity pooling to improve access to Rwandan to health facilities. So this is an example. The other example is you have NGOs, religious-based or not, who own 25% of the health facilities that are treated by the government as public facilities, meaning if all facilities receive an ambulances, they receive one as well at the condition that it serves the people. If all facilities receive a new echography machine, they receive one for the same thing. The condition is price are the same as in public service. They recognize all health insurance. And when they are not Catholic, they provide family planning. And if they don't, there is no fight around this. Don't provide family planning, the government, the community, or the local leaders build a health post near there, not far, and family planning is given there. So the objective, we have very dedicated NGOs and public sectors. We have people that are jobless. We have communities who just want to build premise, and the local government give the material, and you have built a health insurance and make sure that all the countries is insured, and you have an enabling environment protected by a legal framework, because the two previous speakers have said that we need a legal framework that protects everybody. First, the client. Second, the private sector. Third, the material given to each and everyone. And I can go on and go on and go on. But yes, it is possible. Yes, it's an obligation.
Thank you very much, Professor Agnes, for these two really great examples, very actionable, and I hope they are also, useful for our audience. I know, Marianne, that you have a lot of expertise as well on this type of cross-sector partnerships. So I also wanted to get your take on this one.
Yeah, no, thank you, Raquel. And again, thank you to our speakers for spending the time. We've been doing this series with Devex for over a year now, and I continue to be surprised about how much I learn. Very specific, concrete examples about successful public-private partnerships just from these discussions. And I leave thinking, why didn't I know this before? And if I don't know this, somebody who is, really an advocate of public-private partnerships and private sector helping to contribute to the SDGs, and in particular, helping to end maternal mortality. That's what I do every day. If I don't know this, then do other people. So thank you so much for sharing the details, because the devil is in the details. Details matter, because we want this to be more than talk. We want this to be action. We want to be able to spread and scale efficiently and effectively, urgently, because we don't have any time left, quite frankly. The question around barriers, as I was listening to everybody speak, kind of three themes came out at me. So the first was all of you mentioned policies. You also mentioned processes, and then you also talked about perspectives. And I think thinking about the barriers, through that framework, policies, processes, and perspectives, is helpful for me because we have to work at all of these levels if we are to have effective public-private partnerships. One of them in and of itself is not going to be enough. So it's really an ecosystem change and an ecosystem shift. So the policies that, we heard about government policies to formalize, PPMVs. So women and girls can access family planning products in their communities where they may be the only supply of these essential products. Today's UHC Day, Universal Healthcare Coverage. One of the things I'm really looking forward to is ensuring that universal healthcare policy allows for health insurance and health financing that's also provided by local private providers. Dr. Agnes said that the public sector is never going to be big enough to meet the need. And so how do we make sure, that 40 to 60 to 80% of people who are already accessing services at local private providers, how do we make sure that they also have affordability by financing and supporting their consuming of services with local private providers. And I think Dr. Bashir, you talked about how that's already happening in Kenya, in terms of percentage of the cost of antenatal childbirth services that women get from local private providers is covered by the National Health Insurance, which is so great to see, because what this tells me is, we are not coming at this from our own perspectives. We are listening to women and letting them show us, what it is that we should do. We're following in their footsteps. They are moving between public and private sector. So we have to ensure that there are processes that support that movement, whether it's the ability of governments to easily contract, with local private providers. And, Dr. Agnes, you mentioned something that, was really important to me. You said pay for services. Our community health workers, all of these folks that are doing this work, we have to value their work. We have to pay for it. And that is how we have sustainable solutions for the issues and the gaps that we have in our healthcare service. And, we can't, I would add to the point of that, we can't only rely on public sector, but we also we can not rely on donor funding. That is not a sustainable source, of funding for the services that we need. There needs to be strategic purchasing so that we are paying for quality and we're getting valuable health services that are improving outcomes. I don't want to talk too much, but the other thing, I like to say is data. We are learning now during COVID that there is an urgency, to facilitating these partnerships. We are seeing it happen on the ground. Part of what I would love to see is the same kind of digital infrastructure that may be supporting transactions in the Ministry of Finance, are actually extended to support exchange of data in the health sector and ministries of health, because it's through data that we get transparency and accountability, understand where women are going, understand the care they're receiving, understand what the cost and the price is, and understand the outcome. And if there are not the right channels and infrastructure to support that free data flow, we are not going to be able to understand what's happening. And where there's a vacuum of data and information, sometimes people make up their own minds about things. So again, another reason why this partnership with Devex is so important, because we are trying to surface the data that already exist, and we're trying to surface, all of these examples and best practices and demonstrations of how it can work. Thank you.
Thank you, Marianne. And yes, that's right. And we hope that by tracking all this data, all this information, we can also share it with governments, and that can also help produce and draft their guidelines and their policies on this issue. I wanted to refer to a point you made earlier, Marianne, about donor funding, right? About like we cannot always rely on donor funding for everything. And I wanted to ask Dr. Isaac and Dr. Samuel about how your respective governments are leveraging the investments that are being done by donor agencies to encourage precisely this engagement, these investments in local private sector healthcare. If any of you want to jump to the question.
I'm not sure whether I understood, but it's about how does government ensure that the investments in the private sector by the donors is taken up to scale by government? Right.
And that actually also, kind of like also include and try to get to the local health providers at the end of the day. We know kind of like, sometimes how that money, those funds reach to those.
I must say it's not a very easy task for these countries in terms of the economic status for them to really have their wish list fulfilled in terms of service delivery. There are legal entities or articles that guarantee that kind of service delivery to the citizens. Having said that, the government of Kenya is trying its best to fulfill its commitment in terms of at least commodity security. That's where we begin. Human resource for health, the health systems. And there are a few things that may be a challenge, and they require, we require to be supported for a while. We're not heavily dependent on donor funding in terms of commodity, human resource, infrastructure. I don't think there's anything coming from the donor world. And that's quite a big step ahead. Now that we have devolved health system and the funds are following the devolution of function, the counties are enabled to actually handle their HRH issues, handle their infrastructure issues, and their commodity issues. And in the last 7 years, I must say that we have really achieved a huge success in terms of reaching the people. There are more health facilities in the hundreds. There are tens of thousands of health workers that have been employed by this devolution. Initially, all these funds were being held at the Ministry of Health level, and they were just going to specific places where people thought that they had an agenda. But right now, the law has allowed the devolution of funds following the devolution of health functions. And that is one of the issues that has given us success. In terms of what the private sector is doing, the private sector is a partner in this game of us. Being a partner in the sense that there are places where the government may not be able to invest. And our the donor world comes to help in that capacity building, for example, and the software which I alluded to earlier. It is just, as Professor Agnes has mentioned, it is just too much for the public to handle. And the private sector is a partner. Initially, there was the mindset of private versus government. And it was a witch hunt sort of a thing. When the government comes to strike the private sector, it is punitive. Right now, there are laws that can provide, that can support and help the private sector. The public actually is put on task. It's through the what do you call advocacy at the lower level, grassroots level, where the people know their rights and they are demanding. For example, right now during COVID, we had realized that actually private sector plays a very crucial role in what do you call uplifting the burden from the public sector, because there were only very few public sector facilities that had ICU, for example. Right now, COVID, with the pressure it came, it has made us realize some of those things that we will not have realized in the next 10 years. Like the number of beds of ICU that we have, the number of critical care nurses we have trained in the last 1 year is really an achievement. So it is the issue of finding the synergy of how to work together. And we have the infrastructure in place, we have the structures in place and the legal support and policy environment. It is just walking the talk together.
Perfect. Thank you very much for those insights, Dr. Isaac. Actually, just for the sake of time, I just realized we have really two good questions from our audience, very actionable, and I don't want to leave before answering them. So if you don't mind, we'll get to those, and if time, I'll get back to my questions. But I really think the ones from the audience are very good. So we have one from Zad Spinner, who says that data shows a very high infection rate, approximately 15%, for C-section incision wounds in sub-Saharan Africa, sometimes leading to maternal mortality. They are exploring projects in sub-Saharan Africa to help reduce the risk of infections using best practices and products that have been used in the private sector in the US. He's looking for advice in how to pursue this initiative to try to lower, obviously, these infection rates. And he's suggesting, like, collaboration with the ministers of health, how to approach the NGOs to perform pilot studies, how to understand the economic impact. What do you think, or what advice would you give to Sam in this case on how to approach, for example, the ministers of health, or how to approach this piloting of translating solutions from a country where it has worked well to other countries?
I think the minister should speak.
Not only that, but first tell him that in sub-Saharan Africa, there are more than 50 countries. Don't take it like that. It has to be a little bit more focused. And now I let the ministers going on. I have my idea, but let's go.
Do we have any answer from the government representatives, Dr. Samuel or Dr. Isaac?
Yes, the most effective way to tackle this is through the insurance system. From countries, insurance is the best way to be able to look at these issues at the community level, the private sector level, that can subsidize for you to have a quality of care to remove it. That's just what I think can work.
Perfect. Thank you very much. We have also another question, and this one comes of.
We can say also that education. Make sure that doctors that are doing C-section, that are general practitioners, are well trained to do that. Secondly, accountability, because if they have got infection, that means there is something wrong. Most of the cases, if it's so much. So accountability, education, and also insurance will have to pay for what is wrong.
Right. Good point, Professor Agnes. I have a question from my colleague, my reporter, Jenny Leigh-Ravello, who you might know, or you might have followed her reporting on global health on Devex.com. She's saying that, in the middle of the COVID-19 pandemic, there's a lot of interest, obviously, in vaccines. So she's asking the panelists if you could talk about how do you plan to engage the private health sector in providing these vaccines, in the rollout of vaccines, once they are available in your countries, obviously.
To answer that, there is a need for us to have like a mapping of this private sector, look at their strength, let them register, and we can use them. We have a good example in eradication of polio in Nigeria, where we use private sector to get to the hard-to-reach area, even where we have insecurity. We got there through the private sector. So the same thing can also be applied to deliver this vaccine. We've done it before using polio, and we succeeded. So the same approach, the same structure is still available. So where it's not available, they can begin to get ready using best practices that has happened in countries like Nigeria to tackle polio. That is a structure that can be used to deliver the COVID-19 vaccine. Thank you.
Good example. Thank you very much.
Thank you, Dr. Samuel. I'd actually like to add something to that. And, you mentioned building on and leveraging pre-existing systems, that have been used before. I think one of the things that, we think about is the vaccines have to get to the people. And it's about vaccination and how we make sure that the systems are strong and resilient to both support broad vaccination programs, but also to continue essential services. We've seen in the pandemic response phase for COVID how the impact on essential services were dire, for women and girls. There were at least, 40% drop-offs in utilization of antenatal care, family planning services. And so we need to make sure that as we move into a post, COVID pandemic phase, and we move into the next phase, that we are supporting the provision of essential services at the same time that we are thinking about vaccination programs, because we don't want we don't want the same thing to happen.
But they are very
just
good
to follow up.
Yes, go ahead.
Sorry, Professor, go ahead, please.
No. Ministers first, because you talked about the policy angle.
Well, yeah, thank you. Well, I just wanted to reassure the journalist who asked that question that the issue is, will we get the vaccines in time before we talk about the modalities? As far as the modality is concerned, we have initiated, we have brought new vaccines, and the routine vaccines have always been there. We have catch-up campaigns, we have supplementary campaigns, we have all the infrastructure. Our vaccine system, our immunization system is resilient and strong. I just wanted to follow with what Mary Ann mentioned right now, that the essential services actually suffered a heavy toll, and we are silently losing more clients or more people through the essential diseases that we, by loss of essential health services, the hypertension, the diabetes, the immunization, the mothers who are not going for primary health care, antenatal care, deliveries. And as a country, 2-3 months, we thought COVID will come and go in 2-3 months. But after 2 months, we sat and had a task force that was essentially having all partners, the private sector, WHO, UNICEF, the Ministry of Health, the county governments together. And we adopted the operation guidelines for maintaining essential health services amid COVID-19. So it's not going anywhere. So we had, every program had to do its own guideline, soft copies, upload it on the website so that all our health facilities and all our health workers can access. We also disseminated, and we have what you call, how do you provide these services as COVID is ravaging still? And most of the resources, most of the health workers have gone to COVID. what happens to the mother who is carrying a pregnancy and she's HIV positive? Can she get PMTCT care? And I think as a country, we've done that, and we're happy. We are monitoring, and we're also monitoring our data. Our Kenya Health Information System data is giving us the drop on monthly basis, on weekly basis. We are getting our data, and therefore this technology, plus using now the softer copies, not necessarily printing big books, and we are reviewing these guidelines as new ones are coming up. So I think focus on maintaining essential health services is a big plus. If we cannot, if we don't want to lose the gains that we have done over decades. Therefore, that's what I wanted to share as a country. We're on track, and we hope we will be able to. We have also reinstituted the what's called outreach vaccination program, just observing the social distancing and the restriction measures put in place. And life continues because COVID is not going anywhere soon in the next 3 months or so. Thank you.
Thank you.
That's
What
correct.
I would like to add to this is that in Rwanda, we didn't saw a drop in vaccination, a drop in facility delivery, a drop in antenatal clinic, because the Ministry of Health separated drastically COVID centers and usual centers. And the community health workers, 4 per village now, and a village is 1,500 people, continue to push women, parents to use the service of primary care, essential. And essential to build it now because there will be other threats where it will be needed. And also what you say, Marianne, for data, all countries should know that there are great software that are free of charge. The DHS2 is free across Africa. And the partnership between public sector and private sector is in maintenance, selling internet, etc. So there is a lot we can do. There is no excuse to not have data. There is no excuse to not follow it.
No, thank you so much, Professor Agnes. You know, I think a couple of things also came to mind as both of you were talking. You know, so one is, you know, the title of this roundtable is "How do we integrate innovation?" And I think, you know, during the COVID pandemic, we have seen, you know, a flourishing of local innovation to solve, you know, for local challenges. You know, I'll just give one example. You know, one of the MSD for Mothers partners, and Dr. Bashir, I'd be interested if, you know, on your take here in Kenya. We have partnered with Farm Access Kenya to develop a maternity journey platform called Mom Care. It's on a digital infrastructure, Prof. Agnes, as you mentioned, and it's able to track, you know, where women go, you know, what services they need and their health outcomes, and it links to the National Insurance Program. Because this platform enabled, you know, connectivity to women, when COVID hit, you know, very quickly, you know, they were able to add on services, you know, and give real-time information about, you know, which facilities were open, which facilities were closed. If this one was closed, you could go here. If, you know, there's lockdown and you need to go to the facility for childbirth, you know, we can link you to ambulance and transportation service so you can go there. And, you know, that was just one great example of innovation flourishing in response to need. And one of the things, you know, I'm really hoping that we can see is that these innovations that, you know, the urgency of COVID created, making sure we're able to extend them, you know, into the post, you know, COVID time frame. I think it will be really important to do that. Another point I want to bring up, I think it was you, Dr. Bashir, who mentioned, you know, about the negotiations, let's call them, that happen around budget allocations. You know, so we know budgets, you know, budgets are finite, and the need, you know, is huge. You know, one of the things that we can think about in our COVID recovery and around this integration of innovations is how can we increase the pie? as opposed to, figuring out what size of the pie everybody has. And another one of the partnerships Merck for Mothers has is with a development finance corporation, where we're providing blended financing, both grants and debt, for innovations to scale. And one example I love is a social enterprise called Life Bank, which their main business is supplying blood and blood products. And through this innovative financing, they are scaling. I think I can't remember who it was who mentioned the challenge of scale and financing scale. But the other exciting thing that happened is that they added oxygen, to their slate of products in response to COVID. And when we think about responses to COVID, we know that COVID is not just affecting lives; it's affecting livelihoods. Our response is by investing in local private sector, in local social entrepreneurs, in local community businesses. That can also jumpstart economies, because that needs to happen. As Dr. Bashir said, COVID is here to stay, but we need to figure out ways that our health responses can also jumpstart economies.
Thank you very much, Marianne, for these remarks. Actually, we're really close to the end of our session, unfortunately. So actually, I wanted to also ask you for your takeaway on this session. What do you think we should take with us after today's conversation?
So I actually, since I was talking, I'd like to defer.
Okay. Yes, no worries.
Other folks can share the big takeaway.
Who wants to get the spot?
I want to say the takeaway that we can take away is to strengthen policy institutionalization of the private health sector. Okay, I'm already talking. Institutionalization of the private sector involvement in health service delivery is very important. Then within the healthcare financing, I can't leave. I'm already talking.
Yes, we're hearing some voices, on the background, Dr. Samuel.
Yes,
but,
we are.
But I
awesome.
believe.
Let me just maybe let somebody else talk. Let me just leave this place.
No worries. Just no worries. I think we were getting what you were saying with regards to integrate in the private sector with broader in the health communities. Well, I just wanted I don't know if anyone else wants to take.
Can I just quickly jump in? Yes. I've been quietly listening. Just one concrete ask, given all the great contribution. I echo what Marianne said about the need for examples to help us move this agenda forward and case studies. We are always struck by the insights we get from these conversations and how that can actually help us build wider information around these issues. But concretely, those examples really could be very helpful with to inform what the WHO is currently doing in shaping the guidance to countries on private sector integration. So the more case studies, the more examples we can have from countries represented here that feeds into that process. So what David is leading really would help in us being able to move faster and also learning from what others have done already. Otherwise, we continue to have blind spots and reinvent the wheel, and so also repeat mistakes, etc. So I would ask, some of these examples that we've had here be captured, and so that we can feed into that process. Thank you.
Thank you, Tayo. Thank you very much. I agree that we have really heard really good insights from all the panelists and also really good questions from the audience. I'm afraid we're not able to get to all of them, but we have taken note of them, and I'm sure they will, be useful for our research and to also design future conversations. One, in my case, one underlying takeaway that I think goes ahead and beyond this conversation is that really without knowing what works well, what of those case studies we're talking about, those examples that are working well for integrating the private sector and especially local health providers, and what doesn't, what is not, what pilots cannot really be scaled, what really are the barriers and how we can overcome them. Without that type of information, it's going to be really difficult to advance in this movement. So yeah, I'm also joining the ask of to ask donors and NGOs, governments, pretty much all the global health community into joining our efforts on tracking this type of data, these investments, these examples, and kind of like, so we can collect it and use these best practices for all the policy making and WHO work that is going on. One last thing I wanted to say is that in the chat box right now, you will be able to see a link to our latest report on precisely all of these things that we're talking about, how to integrate the private sector in health, especially within the RMNCH ecosystem. You will also find inside the report a deep dive on the Global Fund and how the Global Fund is using some of these examples and to integrate with the private sector. As I said before, we will be issuing new donor profiles, and we will look forward to contributions from all of you. And last but not least, it's been a great discussion, and I personally have learned a lot. As Marianne said, like, it's amazing what you can learn just within in the hour. I want to say big thanks to everyone who came from the audience. Thank you very much for our panelists for the great insights that you share. If you're interested, there's a Devex World session on business transforming development, who's being led by my colleague Teresia Well, happening just now on the Jubilo platform. You will have the details on the chat box as well on how to join that next session. And well, I look forward to seeing some of you there, and if not, in future conversations about how to advance the RMNCH agenda and the integration of the private sector. Thank you very much, everyone, for joining.
Thank you. Thank you, everyone.
Thanks so much.
Bye. Have a good day.
Thank you, everyone.
Thank you. Bye.
Bye.